Hello and welcome to this webinar, Larger Patients, an Ergonomic Approach to Care Based on Body Shape. My name is Sherwood and I'll be taking this webinar for you today. I am a freelance manual handling advisor and I run my own business called Elevate Handling, and I currently provide support for 5 mobility in CPD certified training for larger patients. Today we're going to look at how we can best promote a person-centered approach to handling our larger patients, especially when it comes to body shape. A person-centered approach to manual handling is amazing. It does so many things for everybody. For our carers, the people providing care, everything that we can ask somebody to do for themselves is something that we don't have to support them in. And everything somebody does for themselves provides a sense of agency, a sense of control, if you like, over your environment and the environment you're cared in. We'd like to really raise awareness of how body shapes can influence people's spinal alignment, especially when they're in bed. And then we're going to go through some things that help you kind of see if we can solve those problems for your patients and service users today. So what are we going to cover? We're going to identify the 5 most common body shapes and explain how they kind of influence either in-bed positioning or equipment choice. We're going to look at how in-bed positioning or improper in-bed position or imperfect in-bed positioning can have an impact on the way that we care for people. We're going to look at anterior pelvic tilt and certain body shapes and see how we can improve those things. And really importantly, we're going to apply ergonomic principles to the way that we work. And what we're really talking about there is fitting the task to the person and not the person to the task. And then we're going to cover off some pieces of equipment that you might want to get and also consider ways of using that equipment. So here today we're going to start looking at the body shapes with ascites. Ascites is where we have this kind of increased mass from the chest kind of all the way down to kind of just above the waist. Ascites does a few things in terms of body mechanics and biomechanics. And the first one is that we need to think about kind of where the weight is distributed. The weight is often quite high on the chest and doesn't drop. So what happens with people is that because that weight is high and out in front of themselves, people generally tend to lean back a little bit as they're mobilizing. And this is a contrary to most kind of typical stand patterns, is that we would be leaning forward. So when we are standing somewhere with ascites, often because of where that weight is kind of out in front, if you were to stand in neutral spine with your back completely straight, that weight would be pulling you too far forward. So often what you'll find with, or sometimes what you'll find with ascites patients is they're mobilizing. They're actually leaning back in the first bit a little bit more than most people would. And then only when they're coming through to stand that they are then pulling their weight forward. One of the consequences of this is if you're using a riser recliner chair, you need to get the back of the chair, hopefully you'll have a dual action riser recliner so you're able to operate the back independently from the rise function. And it's really important because if you're rising the chair and you've got a patient that wants to lean backwards in that first part of the stand, you want to be able to get the backrest out of the way so that that patient can stand in their normal pattern of movement. It's really important when we look at manual handling tasks and we think about the manual handling questions. The first manual handling question is, what is normal movement for the task? And here we're really kind of looking at that first. Also with ascites, as we're doing an assisted walk, people generally tend to walk with their shoulders back and their hips out. Again, thinking about that midline, that center of gravity, so that people are walking with their center of gravity kind of in the middle to increase stability. If we start to pull people a little bit further forward, either with slightly lower walking frames or slightly lower gutter arm supports, we're kind of pulling that center of gravity forward, and it may make it uncomfortable or harder for this particular body shape to mobilize. When we come to hoisting, there are a few issues that we may have with our service users or patients with ascites. The first one is an increased mass around the neck and high back slings. If possible, for this particular patient group, I would prefer to have a low back sling. Most high back slings pull the head down into the chest a little bit, and that increased mass around the neck can make it harder to breathe. Allied with this is the fact that that increased mass kind of pushes down onto the diaphragm a little bit, or pushes down and in onto the diaphragm and compromises the amount that the diaphragm, or how well the diaphragm can work. If we're not able to take those full deep breaths, what will happen is we do have poor endurance and a bit of increased fatigue setting in. Again, because of the weight on the chest and around the neck, this particular body shape will not necessarily want to lie flat. And sometimes when we see people not wanting to sleep in bed for long periods of time or prefer to sleep in chair, this is a contributing factor. Appendicitis has a kind of, I suppose it has a slightly kind of higher prevalence amongst men. Normally, if it's possible, we do find a lot of our appendicitis patients with quite a lot of upper body strength, and I would really recommend, if we can, to tap that. Now, if we can with grab handles, that's great. If not, you can look at bed ladders. Those kind of rope ladders that we can attach onto the side of beds often work fantastically well. Moving on to our next body shape. So our next body shape is apple pannus. This is kind of where a pannus or an apron forms and kind of drops down away from the body. The apple pannus has 5 grades, from 1 just above the pelvic area through to 5, which is from the knees and below. What you may find with your apple pannus patients is that they have a typical kind of body shape or presentation from the chest up, and also sometimes the legs can also be fairly typical. When a pannus kind of develops past a grade 3, so the middle of the leg, things do start to get a little bit more complicated, both in terms of ambulation, in terms of mobilizing out of a bed, and also in terms of things like intimate personal care and hoisting. When a pannus is developing, it can sometimes develop onto the non-dominant side. And this is because it's a slow process. It's not something that happens very quickly. And what you may find is that as the dominant side is moving or a little bit more active or used a little bit more than a non-dominant side, the pannus is kind of moved over onto one side. If that hasn't happened, also you might find that the pannus can be slightly harder on one side and softer on the other for a very similar reason. When we're mobilizing or walking with a pannus that's past a grade 3, what you might get is a step and a shuffle. So that kind of adipose part of the pannus may move a little bit more, allowing somebody to take a step further forward and then sliding the following leg on. When we are looking at prescribing slings for somebody with an apple pannus, my favourite type of sling for that, and the favourite type of sling from the patient's point of view as well, both in terms of comfort, is a hammock style sling. It generally tends to incorporate the pannus a little bit better, and also allows the pannus a little bit of space. So we don't get those issues with the leg straps of a sling kind of coming up kind of through the chest and through the pannus, kind of impacting there. Also, with hoisting any larger patients, I would always recommend a 4-point spreader bar. The larger the patient is, the further apart you need that 4-point spreader bar to be, to allow that space, so that we're not pulling people, we're not using the sling and pulling the knees and the shoulders in very closely. We're kind of opening that space up a little bit so that we are able to make this more comfortable and a less painful experience. When you're rolling somebody with an apple pannus, especially if it's past a grade 3, we do need to be careful of the adipose nature of the pannus and that we're not rolling too quickly, or we are supporting the pannus as we're rolling. Because of the weight distribution, apple pannus, the weight is dropped away from the diaphragm, so we don't get as much kind of reduction in lung function as we would necessarily with appendicitis. If your apple pannus patient is getting out of bed, they'll probably, long lying to flat, and then swivel with lying completely flat, swivel with their legs on the floor, and then kind of sit, almost do a crunch if you like, and then kind of sit up and get the shoulders up. When we're looking at seating for apple pannus, we do need to be aware that sometimes people will sit, as again, mainly past a grade 2 or a grade 3, with their legs abducted with the pannus in between their legs. Here we might need to find something to support the pannus depending on how low it goes, but also you would probably need wider seating for that. If we're measuring them in bed, the way that they may be lying flat in bed might be different to the way they're sitting. So with their legs abducted and the pannus in the middle, you may actually end up needing a wider chair. So that is also something to look out for. Again, we were talking earlier about apple ascites and that change in the centre of gravity. Your apple pannus patients will often prefer, again, past a grade 3, grade 2 or grade 1, this might not apply, but past a grade 3 may prefer a flat rise in the seating, so that the centre of gravity is not pitched too far forward too quickly. Issues around intimate personal care with a grade 2 or a grade 3 pannus are quite complicated. One of the products that we'd always recommend here is a product called an octopannus made by Hospital Direct. It enables you to, what it really enables you to do is to stand with really excellent posture, and you can kind of wrap it around the pannus and help to move the pannus out of the way. It enables you to move the pannus kind of up the bed rather than away from the bed, in which some pannus slings do. It's also very effective because you can give it to the service user and they can move their own pannus. And again, that's part of that person-centered approach, something that somebody can do for themselves, increases that sense of agency, means that we are working with them and not doing things to them. It's quite an important distinction. Moving on to gluteal shelf. Now, you can be a combination of all of the body shapes together. You can be apple ascites and Pear adducted. You can be gluteal shelf and apple pannus. They can all be kind of, depending on the presentation. People don't normally fit into one particular category. With gluteal shelf, we often don't see gluteal shelf on its own, presenting on its own. We're normally seeing gluteal shelf plus another body shape. But here, when it comes to gluteal shelf, we want to start thinking about an ergonomic process. How can we use ergonomics to care for these patients a little bit better and make things a little bit easier for our staff? Before we get onto that, let's have a quick look at a gluteal shelf. So gluteal shelf is where we have this increased mass from the lumbar spine around to the the tops of the thighs. A few things that we want to consider here. The first thing is that in order to support gluteal shelf in sitting, we do need a removable lumbar cushion in our equipment that we're providing people. Also, from talking to a lot of patients, sometimes they don't find waterfall backs very comfortable. So it may be that you need a chair, 5 Mobility do a chair, for example, that has a rectangular adjustable size lumbar cushion, which you can change. It's because it's rectangular, you can kind of change the shape of the space that you can kind of increase for the gluteal shelf, or it can be removed completely. That's a really good option and actually very, very comfortable for our patients. The other thing, when we're looking at hoisting a patient with a gluteal shelf, depending on the other body shapes and the issues that we've already spoken about with apple ascites, maybe going for a low back sling, is that we can see slings fitted to gluteal shelf patients that people just get wider and wider with their sling choice. So if the first sling doesn't fit very well, what we'll do is we'll go for a wider sling. And sometimes it's not the problem that we're trying to fix. Normally when we're fitting slings, we're looking at crown to coccyx, and if the coccyx is kind of where it is effectively has moved because there is a gluteal shelf, what you're actually doing is increasing the distance from where the coccyx or the sling would normally fit to where it does actually fit on the patient's body. In this case, if a wider sling isn't working, or the wider slings generally tend to slip and come up into the lumbar area, so that we're not lifting from the coccyx. It's a much more painful hoist and a much higher risk of the patient slipping through the sling. It's actually a case of cut. So sometimes it is like the difference between getting a pair of trousers or jeans from Next or getting one from Sparks. They are cut slightly differently. And the same is with all of the slings on the market at the moment. They're all cut slightly differently. They were, slings from one manufacturer may have a slightly longer leg than the others. The sling from one manufacturer, the high back slings, may be a little bit deeper or have a little bit more head support. So what you're actually looking for here with gluteal shelf is maybe an option to have slings available to you with a longer leg. What's happening is, as a sling fits to the back, instead of fitting to the coccyx, it's fitting to where the gluteal shelf is. So it's pulling the legs back through, pulling the legs of the sling, back through in between the patient's legs. So actually the hip width might be okay, but what's going on is the gluteal shelf is pushing where the sling fits away from where it would normally fit in the center line. So having a longer legged sling available can be really, really useful and can be quite transformative. Again, if we pair this with having a sling with a good amount of adjustment on it, a good amount of loops, different colored loops that we can use, different length loops, having a sling with a longer leg is going to really help support this particular patient group. So we were talking earlier on, I was talking a minute ago about ergonomic thinking and about how we would apply ergonomic thinking to gluteal shelf. Now, if we look at this next slide here, you can see that we have, and this isn't a slide of a patient, this is somebody in an empathy suit. And when we think about the gluteal shelf and we think about where that mass is, often when we're rolling somebody, we're making the bed flat. Now, you can see here in this picture, now I've overlaid kind of some dots where we've got ankle, knees, hips and shoulder. And I've kind of put that little semicircle in there so you can see what happens with the gluteal shelf is that the gluteal shelf kind of pushes that. We have that anterior pelvic tilt as, pushing the hips up, if you like. And if you were to stand like that, or if you were to imagine sleeping in your bed with a large pillow underneath or behind the kind of small of your back, it's very uncomfortable and quite painful, actually, to be honest, for some service users and patients. But not more than painful, but allied to that, when you're in that position, that kind of anterior pelvic tilt, where you're kind of pushed back, there's a few things that you're going to feel. The first thing is that you're going to feel like your head's down. You can see in the picture where the hips are higher than the shoulders, and your spine is going to kind of mimic that. The blood's going to rush to your head a little bit. It's going to feel like the head's down and you're tipping down. That's not what's happening. And sometimes what this can create is a kind of an odd conversation about a lived experience. Your patient may be saying to you, I feel like my head's tilted down, but we're all looking at that bed and we know the bed's flat from experience. But it's not the bed that's going down, it's the angle of the spine is kind of changed depending on where the mass is. And the other thing here is that it doesn't look abnormal. When we do this, or when this is done with our patients, it doesn't look like anything is particularly out of place. It kind of looks as we would expect it to look. It doesn't look like there's anything going on. But it's difficult not to overlay your lived experiences with what you're seeing in front of you. So if that looks flat and that's how you feel the bed would be flat, then that's kind of how we do it. Other thing here is, again, if we're making the bed flat in order to roll somebody, and we're kind of in that sort of anterior pelvic tilt. We've got a bit of decreased lung function going on. We have, much reduced kind of mobility, especially through the thoracic spine, and we have increased fatigue as well. Like if people are fatiguing quicker, they can't help us for longer, or they can't tolerate much. The amount of time they can tolerate these kind of movements is going to be decreased. The really good news is it's really, really easy to fix. And if you're on a 4-part profile in bed, it couldn't be simpler. So the conversation, if you have somebody with a slight gluteal shelf, that I would like you to have with your patient is a bit of an odd one. And that is, do you feel like you're lying flat? Now, it's going to look like your patient is lying flat. But if they have a gluteal shelf, it might not feel like they're lying flat because their spine is not in line. So here what you can see on the screen is we have profiled 5 Mobility's ultra-low bariatric bed. We've overlaid the dots, so you can see now that with the backrest and the knee break profiled, that we're now looking at that neutral spine and we're lining that up across the body. Now, this is the real key, I think, to training. I've been training in handling of larger patients now for nearly 10 years, and myself and 5 have been running CPD certified training courses for the last 18 months. And this is one of the things that we see that people take away the most. When we put people in a shape suit, and shape suit means, well, the shape in shape suit stands for safer handling and patient empathy. What that allows is to build that empathy bridge. So when people are in the suit, they are able to experience what it feels like and how it feels to have your bed flat when you may have like a gluteal shelf, which is kind of pushing your hips out of line, and how it feels to have all the blood rush to your head, and then your position to not feel as it should, or to feel different to how you're normally experiencing it. Here we have the backrest at about 20 degrees. We have about 18 degrees on the knee break, and that's kind of helping to create that kind of spine in line, and keeping the hip also in line through the knee. This works very, very well. It's very effective. And, as I was saying, when we have people in the empathy suits, it's interesting to feel how and hear how comfortable they are, and how the range of movement is increased because their spine is in line, but also how it feels when the bed is flat, and kind of how it feels to have your spine out of line. Over the years, this is something we found time and time again when I've been dealing with service users in their own beds, especially service users that may be confined to bed through one reason or another. It's amazing to have that transformative effect and be able to support service users and make them more comfortable and have less pain, or presenting with less pain when they're in bed. When putting somebody into this position, you need to have a slightly different or unusual conversation, and it's about finding out what the best position is. And we're asking our service user, do you feel like you're lying flat? And then we are moving the bed up and down to find that kind of perfect spot where it feels like everything in the bed is being contoured to the patient's shape. I would also reiterate how important it is to increase in-bed mobility. If we are rolling somebody onto their side into lateral left or lateral right side lying, we want them to help us as much as possible. And we do find that putting people into a more profiled or a more ergonomically correct position from them helps us with that movement. They are able to put more in, and therefore more effort in, I should say, and therefore we as carers don't have to put as much effort in. Every time that we can engage a patient with their own, engage them and help them to move themselves is a win for everybody. Now we're coming to Pear adducted. So again, we can think about ergonomics, and the ergonomic principles are very similar. We have some similar issues to gluteal shelf, as we just spoke about. And with Pear adducted, we have that increased mass on the outside of the legs. Again, we may see some increase of mass on the chest and around the neck, and kind of lower down through the waist. With Pear adducted, one of the first problems we might find here is that your Pear adducted patient is the sort of patient that won't fit in your very popular stand aids, your kind of Sarah Steady-esque stand aid with the seat paddles that come around or come either side of the body. And you may need to look at your Mo lifts or your returns or your rotundas, the sort of products that don't have these kind of seat paddles or side pieces in order for people to fit in. One of the issues here in terms of ergonomics is that if we are rolling our Pear adducted patient, if you are wider through the hips than you are on the shoulders, you are going to be having somebody that feels like they are kind of bent in the middle, as we are kind of that increased mass on the hip. If we put somebody onto that side, it's going to again break their spine out of line. Again, very, very simple fix. Like with our gluteal shelf patients, all we need to do is just profile the bed a little bit so that we are bringing that spine in line. So we're kind of making that shape, using the bed to mimic the shape of somebody while they're on the side. So if you roll them when the bed's flat, because that's easier for them, more comfortable for them, and easier for you as carers, as we get somebody onto that side, it doesn't mean that we can't then profile that bed in order to fit that patient a little bit better. Again here, sometimes depending on where this mass is and the increased mass is around the thighs, as we were talking with gluteal shelf, we might actually need a longer leg sling rather than a wider sling. If, as we were talking about ascites, we have that increased mass around the neck and that increased mass on the chest, I would also probably look for a low back sling so that we're not pulling the head into the chest. Same thing here applies with hoisting larger people. I would always prefer to go for a 4-point spreader bar. The further you can get that spreader bar apart, the better. It's really about the stand aids here and having access to lots of different stand aids. Manual handling equipment is a toolkit, isn't it? And it's one size fits none. It is about having the right tool for the job, and not getting people to fit into things, or trying to get people to fit into things so they don't fit into. Also here, a brief note really about measuring somebody for their hip-to-hip measurement, which can be a bit challenging. Now, if we're measuring for hip-to-hip for seating, obviously that patient can sit up. So one of the best ways of doing that I found, and this works with any patient, is that you would measure the mattress that the patient of the bed of the patient is lying in. You would then get the patient into a seated position using the knee break and backrest function of the bed, and then maybe even a bit of tilt with the Trendelenburg function as well. And then what you do is you measure the edge of the mattress to the hip, or the widest part of the body, depending on how you're fitting the chair or the sling, and the edge of the mattress to the hip on the other side. So you should have two measurements there. So one from the edge of the mattress to the hip on the left-hand side, and one from the edge of the mattress to the hip on the right-hand side. You take those two measurements, you take it away from the width of the mattress, and that gives you a very, very accurate hip width measurement. It can be very tricky. We see lots of people using, two clipboards either side of the hips, or sometimes we may even get people kind of measure kind of over the hips, so we're getting that kind of whole dimension there rather than the measurement through the hips, as it were. And what we're doing there is using the negative space, or kind of space around the patient, to measure them. It's a little bit more dignified because one person can do it on their own, and you can do it quite subtly as well. It doesn't need to be a big song and dance, and we can just get things done. And actually, what I found over the years, been using that method now for quite some time, found over the years that works for kind of anybody really. I can get them sat up. Even better than that, if we were to think about gluteal shelf combined with Pear abducted, You can use the negative space when the space around somebody, I suppose, rather than the negative space when they're sitting on the bed. So what do I mean? So if you have somebody sitting on the edge of a bed, what you can do is measure the distance between the headboard and the footboard, and then measure the distance from the footboard to the hip on one side, and then measure the distance from the headboard to the hip on the other side, and that will give you a super accurate seated measurement. If you need the seat depth as well, you can do the same thing on the mattress if you've got somebody sitting on the edge of a bed. So if you've got somebody sitting on the edge of the bed, you measure again the width of the mattress, and then you can measure from their furthest part of the body back to the edge of the mattress and take that away, and that will give you a really, really good seat depth measurement too. So moving on to the last body shape that we're going to cover today, and that's Pear abducted. With Pear abducted, we see increased mass in between the thighs and certainly around the legs. This has several impacts when it comes to manual handling, mobilization, and choosing correct equipment or equipment that works best for this particular patient group. The first thing, as I said, is as your legs are abducted, you get slightly shorter. Your feet are further apart. You broaden your base of support, and it actually brings you down a little bit in terms of height. The next consequence is that the increased mass around the leg, and specifically behind the knee, decreases your pop height. So the height from the floor when you're seated to the inside back of your leg, effectively the inside where your knee is, becomes greatly reduced. This leads on to several issues or challenges that we may face. If people are unable to get their feet flat on the floor, they may be unable to mobilize. If you're unable to mobilize, and we can have deconditioning set in, especially in the acute setting, also in the community setting, it can lead to people not service users not being able to get out of that bed, which could lead them to not wanting to sleep in it. Like if you don't feel safe or supported, or you don't feel like you have your feet flat on the floor, that can lead to issues around confidence, issues concerning falls, those kinds of things. People, everybody as we stand up want our feet completely flat on the floor and planted. What we find solves this particular issue is the availability of ultra-low bariatric beds. Five has an ultra-low bariatric bed on its rental fleet, and the height to the mattress platform on that bed is 8 inches. I can say now, having worked with this particular bed for a good 19 months now, and previously I would have worked with beds that didn't go as low as that, from instead of 8 inches would have been around the 16-inch kind of height to the mattress platform, that you very quickly forget that the bed is fixing so many of the problems. If somebody's able to get their feet flat on the floor and able to mobilize themselves out of the bed, or to use the flat rise feature of bed to stand them up because they have their feet flat on the floor, we're not having to take so many steps to kind of get best positioning. We're not looking at deflating mattresses. We're not looking at finding the right size steps, or steps with the right safe working load or the right handles, or we're not thinking about, I'm going to hoist this patient out of this bed because I can't get their feet flat on the floor, and then I'm going to put them into a riser recliner chair or a physio plinth or whatever it is, in order to help them stand. So gaining access to beds that go low enough to enable people to mobilize is absolutely, is critical really. It's critical in terms of a reduction of musculoskeletal issues for staff. It's also critical in terms of patient mobilisation and enhancing the patient's journey through our services. The next issue really centres around larger legs. So large legs that may require dressing. It's harder to get a large leg. The larger your limbs are, the harder it is to get them in and out of bed. And again, an ultra-low bed really works fantastically well for this. We see it time and time again in the community setting with ultra-low beds and floor-line beds that have been on the market for quite some time now. It makes getting people with limited mobility in their limbs easier to get in and out of bed, because the lower you can bring the bed, you're kind of increasing the level where the legs can come into bed. So if we're getting the bed close to the floor, there's less space to lift the leg, or less height that you need to lift the leg into bed. And then we can use small little steps or little foam footstools, those kinds of things, to help help people ladder their legs into bed. And again, having an ultra low bed is a way of putting that power, and that the power of doing that, getting yourself in and out of bed, back into the patient's hands. And it is, like I say, it has shocked me how much it changes the patient's journey, and the things, the steps that I was having to take prior to supporting the patients with able to get their own legs, they're able to get their feet flat on the floor. It really is transformative. When we're looking at seating specifically for abducted patients, we may need to bear in mind or think about an increased weight limit on the legs, or the leg support of a riser recliner chairs. Your atypical weight of a leg would be around 8 to 10% of the body mass. For our larger service users, this may change, so we may need an increased safe working load on the footrests of riser recliners. Again, here, I've said it a few times during this webinar, but for Pear abducted patients, what we really need, or what the most success I've had with, is hammock style slings. And here, really in particular, a hammock style sling with a weight bearing pommel. It's a transformative piece of equipment. It enables us to be able to hoist patients or service users where that hasn't been able to be done before, either through associated pain or comfort. And sometimes that, if we have an increased amount of pain and an increased amount of discomfort, we have a decreased amount of willingness for our service users to be hoisted. Having a hammock sling with a weight-bearing pommel helps create a couple of pockets, essentially, to support the legs, so we're not putting so much tension on the inside of the legs. These hammock slings also do more of a lifting of the legs, so the leg doesn't kind of... so the hoists end up lifting the leg more than the leg is kind of coming out of the sling and kind of coming down from the knee. And that kind of can decrease the amount of times that service users are having to support the heels, that carers are having to support the heels or larger legs coming out of bed. When rolling, we do have issues with discomfort, and we may need to look at support wedges or pillows in between the legs, pillows for very short periods of time for pressure relief issues, so that when somebody's rolling, we're not kind of getting this force where the ankles are being pulled together or pulled down, and we've got these heavy edematous legs that are kind of causing some pain through the hips. Use of in-bed systems, in-bed satins, repositioning sheets, those kinds of things to help people turn in bed can be incredibly useful component, and can also help reduce pain and reduce discomfort. With our Pear abducted patients, we do typically as well, not typically, I suppose, there would be slightly higher prevalence of Pear abducted patients that were suited to, won't fit in your typical stand aids. The reason being that as you're abducted, your feet are slightly further apart, and what we see is a trend at the moment in stand aid design where the stand aids are getting slightly larger and the stand aid safe working load is getting slightly higher, but what we're not seeing is a change in the way that stand aids are built in order to accommodate body shape, which is a real shame, and it's something we hope to see changed soon. So that comes to the end of the presentation. Thank you for joining me today. I would also like to thank Five for supporting this particular webinar. This forms part of a presentation that we'll actually be taking through to the National Back Exchange Conference in September, so we do hope to see you there. And if you have any questions, I would welcome to take them from you now.